Greetings, dear learner. We were learning the management of poisoning under the broad guidelines to the general management of poisoning. We finished immediate resuscitative measures, removal of unabsorbed poisons from the body, and in the last class, we finished learning removal of absorbed poison from the body. Under the removal of absorbed poison from the body, we learned the various techniques like diphoretics, enhanced renal excretion, urine alkalinization, urine acidification, hemodialysis, peritoneal dialysis, hemoperfusion, hemofiltration, cardiopulmonary bypass, exchange transfusion, and intravenous lipid emulsion. Today we will be covering the administration of antidote. So, we covered immediate resuscitative measures, removal of unabsorbed poison from the body, removal of absorbed poison from the body, and today we shall start administration of antidote. Then we will manage the patient according to the symptomatic management. Under it, we will discuss toxicodromic management of the patient, then the adequate follow-up and the nursing and psychiatric care. Antidote word has originated from a Greek word antididonai, which means given against. It means a therapeutic substance used to counteract the toxic actions of a specified xenobiotics. Antidotes are classified based on the mechanism of action and the site of action. According to the mechanism of action, the antidotes are toxic effect bypass, inert complex formation, accelerated detoxification, reduced toxic conversion, receptor site blockade, and receptor site competition. We will go one by one. So, the toxic effect bypass, antidotes in this category don't interact with the poison at all. They simply bypass their toxic effect. For example, 100% oxygen in case of carbon monoxide poisoning. So you can see here that in the air, carbon monoxide and oxygen both are there. When the concentration of carbon monoxide increases, so that goes to the blood and it binds to form the carboxyhemoglobin. So the carrying capacity of the oxygen to the hemoglobin decreases. As a result, the tissue gets deprived of the oxygen. While if we increase the concentration of the oxygen in the environment, so automatically this works as antidote that doesn't interact with the carbon monoxide at all. But with the increased concentration, its absorption will increase. So it will be more available to the hemoglobin. So there will be more oxygenation than the carboxyhemoglobin formation. So the more oxygen will be available to the tissues. So this is the mechanism for the toxic effect bypass. That is, in this category, the poisons don't interact with the poison at all. So carbon monoxide here is a poison, but they are not going to interact with the carbon monoxide. Rather, they are simply bypassing the effect of the carbon monoxide by increased their concentration, so they are just functioning in their own way. Then the inert complex formation. Inert complex formation, under this, the poison forms inert complex with the antidotes, rendering it the useless. For like the dicobalt irritate for cyanide poisoning, chelatic agents for the heavy metals, Prussian blue for the thallium compound, specific antibody fragments for the digoxin. Sodium thiosulfate forms an inert complex with the cyanide, forming sodium thiocyanate. So here you can see chelating agents. Suppose a metal is there, arsenic, so for example, and suppose chelating agent BAL, British anti-levishite, has come, it will bind with this metallic metal and it will inactivate them. A complex metallic chelate or is formed, that is an inactive form of the metal, so that it will not produce any effect on the body. So, inert complex formation is the another mechanism of the action of the antidote. Then the accelerated detoxification. Here, the antidote causes the accelerated detoxification of the poisonous compound. For example, N-acetylcysteine is used in the paracetamol poisoning. So, N-acetyl is a prodrug that is converted to cysteine and is observed in the intestine and then into the bloodstream. Cysteine is the key component of glutathione, that is the involved in the metabolism of NAPQI, which is the metabolic product of the paracetamol or acetaminophenol. So 5 to 10% of that acetaminophenol that is converted into the NAPQI causes basically the hepatotoxic effect on the body. So this is the major poisonous substance that is formed in the paracetamol poisoning. So this is metabolized by glutathione into the cysteine and mercaptoric acid, and this is non-toxic. And this glutathione is being formed with the help of N-acetylcysteine. So this causes the accelerated detoxification of the paracetamol. So in this way, the liver damage is prevented. If the glutathione is lesser in content, so NAPQI will act in this metabolite on the liver and will cause the liver damage. So in the metabolism of the paracetamol, the glutathione helps in the metabolism of NAPQI, a byproduct of the paracetamol metabolism, which is usually hepatotoxic. So by accelerated metabolism of NAPQI, acetylcysteine prevents from hepatotoxicity of paracetamol by accelerated detoxification into cysteine and mercaptoric acid. Another mechanism is the reduced toxic conversion. Here, the antidote reduces toxic conversion of the poisonous substance to a more poisonous metabolite. For example, ethanol. In case of methanol poisoning, ethanol are given. How it works is interesting, that ethanol, methanol, ethanol and ethylene glycol all are being metabolized through the alcohol dehydrogenase. So they have a common enzyme that causes their metabolism, alcohol dehydrogenase. Methanol is converted into the formaldehyde and formate and formic acid. And formate and formic acid and formaldehyde are the toxic metabolites of the methanol. They causes the most of the toxicity due to methanol. So if alcohol dehydrogenase, the enzyme that causes metabolism of methanol, is engaged in some other metabolizing process, so it will be lesser available for the methanol. This is what the ethanol does. Ethanol, when given to the patient of the methanol poisoning, causes the alcohol dehydrogenase to be utilized for ethanol purpose. So ethanol uses the alcohol dehydrogenase in the conversion of ethanol to acetaldehyde and then to the carbon dioxide and water. So it is not that poisonous, and this alcohol dehydrogenase gets engaged with the ethanol. So methanol gets lesser in quantity, converted into the more toxic metabolite, that is formaldehyde, formate or formic acid. So in this way, this causes reduced toxic conversion to the more poisonous metabolite of any toxic substance. Then another mechanism could be receptor site blockade. Here what happens is the antidote causes the blockage to the receptor on which the drug or the poison acts. For example, atropine is an anticholinergic drugs and organophosphorus compounds are the cholinergic drugs. So, organophosphorus compound acts on the cholinergic receptors, that is M1, M2, M3, NN, NM receptors, whereas atropine binds to these receptors causing antagonism, or you can say that it no effect of the organophosphorus compound. With the help of this, the effect of organophosphorus on the body gets reduced. So, here this is the receptor for the suppose organophosphorus compound M3 receptor or M1 receptor here. So, this organophosphorus binds to this M1 receptor and shows its pharmacological response. But once atropine is given, instead of the organophosphorus compound, this atropine binds to the receptor site, so doesn't allow acetylcholine or the organophosphorus compound to bind this receptor. And so, the no pharmacological response of the organophosphorus compound is produced and the patient is saved from the poisonous effect of the organophosphorus. Then, receptor site competition is the another mechanism of action of the antidotes. Here, for example, naloxone competes for the opiates receptor. So, opioids work on the mu receptor, opioid receptors. So, naloxone also has the same competition for the mu receptor. So, if we increase the naloxone, it has more affinity for the mu receptor. So, it will not allow opioid receptor to the bind to the receptor side. So, the pharmacological action of the opioid is prevented. So, here this is the receptor site competition, whereas in atropine it is the receptor site blockade. So, both are the different mechanisms. This is about the classification of antidotes based on the mechanism of action. Then the classification of antidotes based on the site of action. So, based on the site of action, the antidotes are classified into 5 types: mechanical or physical antidotes, that is, they cause the mechanical or the directly interaction with the poison and stop their action. Then the chemical antidotes, then the chelating agents, serological antidotes, physiological or pharmacological antidotes. We will come to each of them one by one. Antidotes may counter the poison when they are within the gastrointestinal tract, or when they are in the blood, or when they are acting on the target cells, that is at the receptors. Mechanical antidotes act inside the GIT, gastrointestinal tract. Chemical antidote also act inside the gastrointestinal tract, whereas serological antidotes acts inside the blood and the chelating agent also acts inside the blood. The physiological or pharmacological antidotes acts at the target cell or the receptors. So, coming to each of them, then so in the first of one is the mechanical or physical antidote. So, mechanical or physical antidote, as the name suggests, works mechanically on the poison within the gastrointestinal tract. So, they directly interact with the poison and stop their absorption or their action, dilution, they dilute them like that. So, based on their action, they are classified into adsorbents, demulcents and diluents. Adsorbents are the antidotes which adsorb the poison on their surface. For example, activated charcoal. So, within the gastrointestinal tract where the poison is at the initial stage, they will bind with the poison, they will adsorb those poisons on their surface and cause their excretion out from the gastrointestinal tract through defecation, and will not allow the absorption of the poison. Then the demulcents are the antidotes which prevents absorption of poison by making a protective coating on the stomach wall. So they form a coating over the stomach wall, demulcent, so it will not, poisonous substance will not get absorbed from the stomach surface. So most of absorption of the poison happens in the stomach or the proximal part of the small intestine. So by forming a layer between the wall and the poison, it will cause no absorption of the poison from the stomach or intestine. For example, milk, ghee, oil, butter, we will come to them after certain moments. Diluents are the antidotes which dilute the poison, rendering them ineffective, like plain water, bulky food. So, they basically dilute the concentration of the poison and causes the less adverse effect on the body. It is seen that most of the antidotes work in both the ways, more than one way, like milk act as a demulcent as well as the diluents. So in this way, we classify the mechanical or physical antidotes. Then coming to adsorbents in detail. So adsorbents are the antidotes that absorb poison on their surface. For example, activated charcoal particularly, and the bentonite is the another good example of the adsorbent. Bentonite are particularly used in form of the calcium bentonite, which is the major constituent of the fuller's earth that we know very commonly know, multani mitti. Multani mitti, known as the fuller's earth, that contains bentonite in form of calcium bentonite that acts as an adsorbent. So it may be used for the adsorption of the poisonous substance. It is fuller's earth is most commonly or mostly recommended in case of paraquat poisoning. Fuller's earth was once used by the fullers, workers who clean the clothes, particularly wool, to eliminate wild dirt and other impurities. This is called as the fueling. So it was used to clean the clothes, and then it was found that they may be used for the washing away of the poisons. So it was used mainly for the paraquat poisoning. It causes adsorbents basically have the large surface area. They absorb the poison with them and they get excreted from the intestinal tract. Then we must know the detail of the activated charcoal. Activated charcoal is the most important adsorbent and also known as activated carbon, activated coal, activated charcoal written as AC, then medicinal carbon, then medicinal charcoal. As far back as in 1981, Rumack, a renowned toxicologist, wrote in an editorial, although we are all hesitant to induce vomiting in a patient who may become comatose before emesis occurs, some patients would not tolerate intubation and lavage. It may be that the safest management would consist of large doses of activated charcoal with no effort to empty the stomach. So in 1981, the Rumack recommended charcoal for the management of poison, that also better than the emetics. More than 20 years later, this statement has turned out to be prophetic. A number of recent studies have now documented clearly the efficacy of activated charcoal as the sole decontamination measures. While emesis and lavage are increasingly associated with relative futility. It is a fine black odorless powder. As you can see here, it can be available in different powdery form or in the tablet form, capsule form. So this is basically fine black odorless powder recognized for long as an effective antidote for the poisoning. Charcoal has been used for the medical purpose for the thousands of years. The Egyptian papyri document the use of charcoal to 1500 BC. In 1831, French pharmacist Pierre Toury conducted a bold demonstration. At a meeting at the French Academy, he ingested several times the lethal dose of strychnine with the equal amount of charcoal, and surprisingly, he survived. It was until 1963, after the Holt published a review article in the Journal of Pediatrics entitled The Black Bottle, that activated charcoal became widely accepted in the management of ingested toxins. So, in this way, the use of the activated charcoal developed for the management of poisoning. But overall, as is true for the other method of gastrointestinal decontamination, there is lack of sound evidence of its benefit as defined by clinically meaningful endpoints. This opinion is reflected both in consensus statements and in overall trend towards no contamination. The consensus opinion concluded that a single dose of activated charcoal should not be administered routinely in the management of poison patients. And based on the volunteer studies, the effectiveness of activated charcoal decreases with the time, providing the greatest benefit within 1 hour of injection. There was no evidence that the administration of single dose of activated charcoal improved the clinical outcome. Additionally, it is generally accepted that unless either airway protective reflexes are intact and expected to remain so, or the patient's airway has been protected, the administration of activated charcoal is contraindicated. So, airway shall be protected before administering the activated charcoal. Then, it is how this is formed. It is a form of carbon that has been processed to make it extremely porous. As you can see in the photograph, it is a microscopic view of the charcoal where the porosity of the multiple pores, innumerable pores are there on the surface of the charcoal. So this porosity makes this develops the ability to absorb the poisonous substance in their structure more. And this adhesion of the poison is done through the hydrogen bond or the van der Waals forces that you already know in the chemistry. So, it is a form of carbon that has been processed to make it extremely porous and thus to have a very large surface area available for the absorption of the poisons. Activated charcoal is prepared by destructive distillation, that is heating in the absence of air of the carbonaceous substances. So, carbonaceous substances like wood, pulp, bone, starch, petroleum, lactose, sucrose and coconut shells are heated in the absence of air, that is called destructive distillation, and from there this activated charcoal is obtained. This process opens up the millions of the teeny pores between the size of the 10 to 1000 angstroms between the carbon atoms, and this increasing the surface area enormously, that is around the 1000 square meter per gram of the surface area. This allows activated charcoals to absorb large quantities of poisons on its surface. Then another type of the activated charcoal that was developed was the super activated charcoal, also known as superchar, and it was marketed in 1996, and it has surface area of the double the normal activated charcoal, that is around 2500 to 3000 square meter per grams. The adsorption, as I told you, occurs by the hydrogen bonding and the van der Waals forces. Poisons are best absorbed in the non-ionized form. Strongly ionized molecules like hydrogen chloride, nitric acid are not absorbed with the help of the charcoal. Then the activated charcoal is typically given after the gastric lavage. I already discussed with you while talking about the gastric lavage that after gastric lavage, it is the usual manner or it should be done that the activated charcoal shall be left in the stomach after the performing gastric lavage, so that the poison that has been left after the gastric lavage or those poison who are coming after the intrahepatic circulation will be absorbed by the activated charcoal. It is considered to be the single most effective antidote available today. This is usually given in the dose of 70 to 100 gram mixed in about 250 ml of water for the adult, and for the pediatrics group it is given in the 1 gram per kg of the body weight. That is C for corrosives and cyanides. They are not absorbed by the activated charcoal. Then L for the lithium, I for the iron, M for the methanol metals except the inorganic mercury. Inorganic mercury is absorbed by the activated charcoal. Then ethanol and ethylene glycol. These all the compounds or the metal or the poisons mentioned as a climb are not absorbed by the activated charcoal. Then how it works basically, again after a pause for the this slide. Then certain drugs and poisons are not absorbed by the activated charcoal. You can remember it by the mnemonic CLIME, climb. So the corrosives and cyanides are not absorbed by the activated charcoal. L for lithium is not absorbed. Then iron, I for iron is not absorbed by the activated charcoal. Then M for methanol metals are not absorbed by the activated charcoals. But among the metals, inorganic mercury can be absorbed by the activated charcoal. Then E for ethanol and ethylene glycol are not absorbed by the activated charcoal. Then how the activated charcoal works. It basically absorbs the toxic substances inside the gastrointestinal tract. So it causes doesn't allow the absorption of the poison from the GI tract to the blood or the other organs of the body. So this is one mechanism of preventing, that is the absorption of toxic substances. Then for selected drugs, it increases the clearance by interfering with the intrahepatic recycling. I already told you that the drugs that are coming from after the intrahepatic circulation, that is comes in contact with the activated charcoals and they cause its absorption and the excretion of the drug without getting reabsorbed in the liver. So another mechanism can be by lowering the intraluminal concentration of poison in the gastrointestinal tract. So activated charcoal creates a concentration gradient between the blood and the bowel fluid. So the intraluminal concentration of the poison, as it will excreted out from the GI tract along with the activated charcoal. So there is a lesser concentration in the GI tract and the higher concentration in the blood if certain drugs or poisons have been ingested intravenously or in the parenteral route. Then in those cases, there is a concentration gradient between the GI tract and the blood. So it will cause the more of secretion of the drug or poison into the GI tract and more excretion with the help of the activated charcoal. So it is recommended that it shall be given in multiple doses. I will be coming to the next slide where I will be talking that multiple doses activated charcoal is the current regimen that shall be prescribed for the patients of the poisoning. So then, in addition to the sorbitol, if it is given along with the sorbitol, then it causes hyperosmotic laxative action causing catharsis. So in this way, it causes the excretion of the poison from the body. That is one, by inhibiting the absorption of the poison, then by increasing the clearance by interfering in the intrahepatic circulation of the drug, then lowering the intraluminal pressure or concentration of the poison in the GIT. So it causes the concentration gradient between blood and bowel fluid. This increases the flow of the poison from the blood into the GI tract, a process also known as gastrointestinal dialysis or the gut dialysis. And then if given with a sorbitol, then it shows the laxative action and excretion of the poison. Then black and gritty nature of the activated charcoals makes it unacceptable for the patients, especially among the children. This problem is overcome by giving it with a flavoring agents like chocolate, cherry syrups, ice cream, sherbets. Then we can also recently with the Coca-Cola, it has been mixed so that it will be not looking problematic for the children's. Then certain adverse effect that is important to know with the activated charcoal, that is the black tongue is the common finding and the black stool after the activated charcoal. Then constipation can be possible. Then intestinal obstruction might also be another complication. Vomiting in certain patients, diarrheas also with the possibility. If it is spelt on the eyes, then it may cause the corneal abrasions. Then if given through after the lavage or having the vomiting, then aspiration of the activated charcoal can cause aspiration pneumonias. Then certain of the important contraindication where the activated charcoal shall not be given must be known for the clinician. The one important is the intestinal obstruction, then perforation of the any intestinal lumen, then patient at the risk of hemorrhage or the gastrointestinal perforation. Then there are certain other contraindications that may be remembered with the mnemonic FIALS. P for pesticides, petroleum distillates, unprotected airways, H for hydrocarbons, heavy metals, I for iron, ileus, intestinal obstruction, A for acids, alkali, alcohols, altered consciousness, aspiration risk, L for lithium, lack of gag reflex, S for solvent and seizure. So this here the not absorbed category will already include under the contraindication. Along with that, pesticides, petroleum distillates, because they will have the chances of aspiration pneumonitis. Unprotected airway, already tell you, if the airway has not been taken care, then it is contraindicated. Then hydrocarbons, then heavy meal, already it is not absorbing the heavy metals. Then iron, intestinal obstruction, ileus, acid, alkali, corrosives, it is contraindicated. Then alcohols, then altered consciousness, aspiration risk. Then lithium, already it is in the not getting absorbed, lack of gag reflex, solvents and seizures. All these are the contraindication for the activated charcoal.